My name is Markus Fahlström, and I'm from Uppsala University. For those who knew Anne-Marie Larsson, she was my supervisor some time ago. And I also had Professor Adam Espe Hansen as my opponent during my dissertation. So today we're going to talk about cerebral hemodynamics in Moya Moya disease. And I have no actual or potential conflicts of interest in relation to this presentation. And this research, which I'm about to talk about, is partly supported by Swedish Brain Foundation and the Swedish Stroke Association. So I'm not a doctor. Yeah, I'm a doctor, but I'm not an MD. So of course, I will fail a little bit when presenting this disease to you. So Moya Moya disease is it's really rare cerebrovascular disease causing a chronic progressive stenosis in the terminal portions of the internal carotid arteries. During progression, we will see a compensatory development of collateral vessels at the base of the brain. These are called, this resembles a puff of smoke appearance on the DSA. So clinical presentation varies between children and adults. And there is, at the time, no known treatment to reverse the process. Instead, focus is on decreasing the risk of future strokes. Antiplatelet therapy is suggested. Direct or indirect risk evaluation may be indicated. There is also a difference between the Western population and the Eastern population, which I won't go into details though, but there is. So, Suzuki grading system is commonly used to follow the progression of the disease. And we have the narrowing of the ICA apex, and we have the initiation of the Moya Moya vessels, the Moya Moya collaterals. The ICA stenosis will progress over time, and eventually there will be a total occlusion of the ICA, and you will have blood flow supported by the ECA collaterals instead. So, Moya Moya disease in Sweden is included as a national specialized medical care service between Akademiska sjukhuset or Uppsala University Hospital and Karolinska University Hospital. And I said it really is a rare disease. We had 15 diagnosed patients during 2023, according to the National Welfare Board statistics. And 8 revascularizations surgeries were performed. So, this is what I found intriguing. This is, as an MR physicist, I should be interested in MRI, but this is really something that makes my brain tick. So, during the cerebral perfusion pressure will progressively decline as the disease progresses. And this will trigger a compensatory response from several mechanisms to try to keep the cerebral metabolic rate of oxygen constant. As the perfusion pressure declines, the risk of future stroke also increases. So this is adapted from other papers, and there is a review cited in the on the back, not on the back, below the text. So we have, of course, have a decrease in CBF, and we have collaterals developing, and we have the oxygen extraction fraction trying to compensate by increasing its extraction. And we have autoregulation, which will dilate resistant arteries in the brain to increase the blood flow to the affected regions. And this is done to keep the CMRO2 stable. So we find it important to evaluate the degree of compensation to assess the future risk for these patients and to follow up after surgical intervention. So DSA is today standard for collateral grading. Diagnosis is Suzuki grading. And as we have touched upon briefly during the last session, 15 gas is the standard for OEF and CMR2 measurements. And it's also a standard with water as a tracer for CBF and CVR measurements. So we want to assess these compensatory mechanisms with MRI instead. But of course, this is difficult. So from our institution, we have 31 patients at the moment with a total of 73 examinations. We have some longitudinal data. And what we do, which I also know that not all do with ASL or with MRI, PET being the standard reference, is that we use ASL, arterial spin labeling, to measure CBF before and after injection of acetylcholine. Acetylcholine is a substance that dilates the vessels in the brain. So CVR, or the cerebral vascular reserve, is defined as the ratio between the increased CBF due to acetylcholine injection and compared to baseline. So this is just a example map from voxel division by 15 minutes after injection and baseline. Those CVR maps I will show today is, of course, based on the 15 minutes. Since we're doing several time points, I need to choose one. When we do region CVR values, we are modeling them or choosing the maximum within the actual measurement challenge. We also perform DSC perfusion. This is done 30 minutes after injection. So I need to emphasize that the injection should affect the data. So this is not a baseline examination. This is a DSC perfusion where the cerebral blood flow should be increased due to the injection of acetylcholine. I reprocessed all the data when I got the new version from Circle Medical. And in this talk, I'm going to look more on OEF and CMR2 as output from the software. And bear in mind, this is not really OEF and CMR2. There are estimates based on the model, which we have seen before today. So when I say OEF, I don't really mean OEF in terms of the absolute quantification made by PET. Still. So I have some cases. So I want to show a dynamic magnetic resonance angiography. I will let it run for a couple of times. So this is a patient with unilateral Moya Moya disease. It's a right side Suzuki grade 2 to 3. It's male, 29 years at the examination. So what we expect here is that OEF should be increased on the affected side. We also expect that CVR should be decreased on the affected side. We would like CMR2 to be handled or to be constant between the sides. This is not the case. In general, we see a slight increase in CMR2 as calculated by the software. This is not really visible in this image, but trust me, it's what we see, and we will see another example of this also. But it's quite clear that the OEF is increased, and CVR is measured by independently, of course, of the OEF. So we more or less expect to see this. I have another case. So there are a few unilateral patients in the cohort because it's not as common as bilateral disease. So this is a right side Suzuki grade 2, a female, 41 years. And I want to show this contrast in the MRI is not that good, but you can clearly see the difference between the right and left side. I can play it again. So in this case, we also expect the OEF on the right side to be increased on the affected side. We also want to see that CVR is increased on the right side. and more or less a equal CMR2. Although I don't really like to look at images, I like values. It's it's hard to present standard deviations in the images, but this is just a visual example. But this is more or less what we expect. So we have at the affected side, we have the increase in OEF. We have the increase. No, this is not correct. This actually seems like to be an increase in CVR. That's not what the image I pulled forward. So that's something wrong with that. I think I have turned the axis around. However, let's skip the thing instead. This case is an unverified unilateral MMD. I did not see. I didn't have time to talk to our neurosurgeons about this case before I left. And this is one of the newest patients we scanned, and you can see some difference between the right and left side, especially maybe at the middle cerebral artery, I guess. But if you look at the OEF, CVR, and CMR2 maps, you see the same pattern that we would like to see, except for the increase in CMR2, which we can discuss how many times, but I don't have an explanation for that at the moment. The last case is actually a bilateral patient, and so these are the more typical patients. They are very heterogeneous population. Some are operated on, some are not operated on. So it's very difficult to draw any distinct conclusions. If you look at the MRA in this case, you can see that they are mainly supported by other vessels than the ICA. But on the OEF and CVR and CMR2, we see some patterns which I really can't explain. We see a decreased posterior on the right side, decreased CMR2, which seems to be fairly consistent with the lack of OEF in that same region, but there's a large increase in CVR. This patient has Suzuki grade 4 on both sides. Is 28 years old and it's a female. So yeah, I'm presenting this. I can go back if there's any question on this. As I said, I'm a physicist. I don't look at images. Usually we do a regional analysis. So I'm going to just wrap up with this as well. And we use a arterial atlas, which recently was published in the scientific data, which is generally spatially normalized to the patient-specific space using FLIRT or SPM12 common data processing tools. We extract the regional data from those regions, which include the anterior, middle, posterior cerebral arteries and vertebral basilar regions. We processed all the data during this week. I didn't have time to do a thorough statistical analysis, just preliminary data and how it's distributed. So we usually consider the MCA affected. We take away the unilateral cases with unaffected MCA. VBA is generally considered unaffected. We don't have many patients with posterior involvement. So we would expect OEF to be higher in MCA compared to VBA. And that's also what this estimation plot shows based on the pair samples in patients. But we still don't know the difference between MCA and VBA in a healthy population. And as Johan talked this morning about good research conduct or how to summarize it, I usually stress that how does things look in a healthy, unaffected control group compared to the patients is something which is of significance when doing research, especially this kind of research. So we don't generally use the data from CMN in clinical practice. This is only research. We're collecting data as we go. Of course, there might be potential. We will continue to explore the possibilities with the software and other parameters such as CTH. And I also saw that there were hyperperfusion lesions now in the newest version, and I have only seen that we do see hyperperfusion lesions, and I would like to see how they, on the longitudinal data, changes with time. We're also starting to collect healthy control data to compare our data with, to get a better understanding of how we compare these parameters and what they actually say. This will be done on a PET-MR system, so we will also do at least 15 of water PET to get the absolute quantification of CBF and CVR. With that, I would like to thank you for your attention.
Thank you so much for sharing these exciting data. Are there questions? Well, I have a comment. I think you would expect your CMR2 to be on the high side. So that's what we talked about just before, is that you have a microcirculation that you measure, and that provides you with an OEF that tells something about how much oxygen can I extract. But because you inject acetazolamide, your neurovascular coupling is off, if you will. So you would expect to see higher values there. We looked at this at some point in some CO2 inhalation, where it actually seemed like the microcirculation changed to maintain neurovascular coupling. But here I think maybe it is to be expected, but it's certainly a very nice data and very encouraging. Yeah.
Thank you very much, Markus. What PLD are you using?
2,500. So we have increased the PLD to try to compensate for the delayed flow, and of course this is a limitation with ASL. I know it, and so we have noticed that the patients with higher grade of Suzuki grade has also this delayed flow, the collateral flow, and this in turn will be bad on the ASL. We're also trying a multi-delay ASL, but we have not implemented that after the acetylsololamide challenge yet. So, but I'm well aware of the issues.
Yeah, there's a study from Stanford where they use PET-MRI, the same GE scanner that you have, and compare that with water, where they found false lesions in about 40% of the patients, basically. And of course the issue here, and that was with the Hadamard multi-PLD implementation. And of course the issue here is that you're dealing with a labeling with a half-life of a second or something like that. So if you have any collaterals that delay the arrival of your label, then of course you get a false lesion. And of course their approach, which you can also think about, is of course to use AI to correct the mistakes in arterial spin labeling. So you use water PET as the reference, of course, in order to improve your techniques, and that's something you can consider, of course, also for your company. Yes. Thank you.
Do you have some patient before and after surgery?
Yeah, we actually have a paper published, a small case series in ACTA Neurosurgical, but we only do the multiple borehole surgery at our institution. So when we look at these large regions of interest we use, we see some potential increases, but I won't give too much hope on that. There needs to be other ways of analyze that, which to cover some of the limitations. But we have.
So at Karolinska Uppsala, we're sharing these patients, and we do direct high flow revascularization, and we do also systematically do. We don't do this. We do acetazolamide with a baseline, and then we wait and do another DSC. But the results are really hard to interpret.
Yeah.
It's really tricky because with AIF, just selecting the AIF, you're changing so much, and you're changing stuff with the parameters that you sort of a priori use in the circuit system, that it's really, really tricky to try to understand what's happening.
We had a second opinion case from Karolinska where we had the, I don't know if you've used Circa for the perfusion calculation, but we had they had a hyperperfusion lesion after acetazolamide, but not before. But I didn't pay much attention to that at the moment, but it's difficult. It's complex.
It's the most confusing vasculature I have seen.
No, yeah. I mean, you can say these are children and young adults. They're getting an operation. The perioperative risk for stroke is about 4%. So why do you want to do something like MRI, which is inherently unstable, when you have a really good water PET center in Uppsala with Markus
I know.
Professor in water. So why take the risk? I mean, you can do artificial labeling, but not as the only thing. I mean, the primary thing should be water, and then of course you can do artificial labeling and develop other techniques. But I mean, again, these are children. So patients first.
Yeah. We don't have so many children in this case, and we usually do only MRI and don't use acetazolamide in children actually. But that's not my decision to make. It's for the neurosurgeons. But Mark was my supervisor also, and I have had this discussion. And for the future, I would really like to do a PET study on this patient with healthy controls, but I want to use filtranol gas before and after acetazolamide to see if there are any changes in the dynamics of the response to acetazolamide between healthy controls and patient. But I might be a PET physicist in 10 years, I don't know, but I work closely with Mark.
Thank you so much for that brilliant presentation and questions.